Good evening, everyone. Thank you for attending our Cincinnati Children's School Community Forum addressing COVID-related questions that you might have. And can I please have the next slide? So these are our panelists for this evening. It's a variety of people. Dr. Robert Frank, who is our director of the Vaccine Research Center here at Children's. I think he's a very important source of information because he has been on point and leading the trials that have led to approvals of the various vaccinations. Dr. Joshua Shafson, who is an infectious disease specialist and our director of infection prevention and control. And he's been our leader really throughout the pandemic in keeping 16,000 employees here at Children's Hospital, keeping them safe while we see patients around the pandemic. So I think he has a lot of expertise to lend here. Many of the lessons that we've learned here, I think, are applicable to schools. Ann Swenson is our project administrator. She's the one who's been keeping us on point now for over a year. And we're very grateful to her for arranging this and keeping us together. And I'm Hector Wong. I'm the vice chair of pediatrics here at Children's. Next slide, please. So we have been holding these forums on a monthly basis for over a year now with your respective school administrators, superintendents, principals, school nurses, and so forth. Very early on in the pandemic, we decided to do this. We expanded it across really our entire region, not just Cincinnati, not just Hamilton County, but all of our surrounding areas. And the goal there was to provide them with as up-to-date information as possible regarding infection control, vaccines, COVID rates, and so forth. Over the last month and a half or so, we've been fielding a number of requests from individual schools wanting us to come out and speak at meetings for the respective school boards. And to put it simply, we just don't have the bandwidth to do that on a one-off basis across multiple regions. So as a compromise, if you will, because we do want to help, we decided to have this forum to specifically address questions that families of our students might have. What we have told our school administrators in the past is that we're not here to endorse or reject any particular school policy. That's something that's really up to the local administrators along with their health departments and their respective parents and families. What we are here to do is provide you with as accurate of scientific information as possible so that you integrate that into your decision making. We're very committed to partnering with the schools and with the families because I think we all share the goal of getting our kids in school 5 days a week in person because we all believe, and I think we can all agree to that that's really the best thing for them. So our goal is to provide you with some information as to how to best do that and do it in a safe way. So Ann, next slide, please. Most of our forums, we've provided sort of a community update to give you a sense of what's going on in the community in terms of rates of COVID. So next slide, please. This is a common way of showing the data. It's the 7-day moving average across our 14-county region, and it's important to note that it's indexed per 100,000 population. And what this graph is showing you is that early in July, we were in a great place. We were in the single digits, 4 or 5 cases per 100,000. That was a really good place to be. But as you've seen throughout August and continuing on into September now, we are at about 60 cases per 100,000 population. That is not a good place to be. In fact, that exceeds the threshold for Hamilton County to declare a special alert in terms of high COVID transmission. Again, this is for the 14-county region as a whole. Next slide, please. This is really the same data shown in a little bit of a different way. I don't want to get too much into the details, but it's broken up per county. And as you can see there is some variability with some counties having double the amount of cases as compared to other counties. So there is some variability. All the counties are not in a very good place. Some are in a worse place than others. Next slide, please. So one of the things which we assume is top of mind for all of you is that has to do with vaccines and any updates that we might have. If we could have the next slide, please. I believe I'm covering this slide, and then Dr. Frank will cover the rest. So, we would suggest that right now, vaccines are the most effective mitigation strategy against COVID-19. I think, in our opinion, we are very, very fortunate that we have these vaccines and that they're so safe and so effective. They prevent illness. That was the major goal of the vaccine, was to prevent major illness such as hospitalizations and death, and they continue to be very effective against that. Something that's a bit nuanced is also that vaccines prevent the emergence of variants. And again, without getting too much into the weeds, the reason for that is that these variants occur by random chance, if you will. The viruses replicate millions and millions and millions of times in our bodies when they infect us. During that replication, sometimes the virus makes a mistake in their genetic code. The majority of the time, the mistake doesn't make any difference whatsoever. Sometimes the mistake is actually detrimental to the virus, and sometimes that mistake actually gives the virus some kind of advantage. And those are the bad mistakes, and because that can make the viruses either be more infective or more virulent or more lethal. And I think that's something that we're seeing right now with the Delta variant. So in many ways, these vaccines are a very good way to prevent against these variants. Yes, we are starting to see some breakthrough cases, but as Dr. Frank will talk about, it's important to understand what those mean, whether it's just people who are positive versus people who are positive and becoming sick. So the vaccines are very effective. They continue to be so. Back in January, February, they were very scarce. Now they're widely available. They're free. There's an authorization down to kids of 12 years of age and above. And over the weekend, you may have seen that Pfizer submitted data to the FDA, or is about to submit data suggesting that it's very effective and safe for kids in an age range of 5 to 12. It's important to understand that what was in the press over the weekend was a Pfizer press announcement as opposed to formal FDA approval. Now the FDA needs to go into its process and look at the data carefully, and we're hopeful that sometime in late October, maybe early November, they'll come out with an announcement, they meaning the FDA. So, Ann, can we have the next slide, please? And I think from here, we're going to let Dr. Frank speak to safety and efficacy. And again, I would remind our participants today that Dr. Frank is really locally the leading expert in vaccines. He's been doing this for many, many, many years, designing, studying, and evaluating vaccines. So I don't think that you could have a better source of information. Dr. Frank?
There it goes. Thank you, Dr. Wong. And so I think that just to reiterate what Dr. Wong was saying, the first thing that we want to look at as far as with any vaccine is safety. So if it's very immunogenic, it makes a good immune response, it's very protective, but it's not safe, the vaccine is no good and we won't use it. And so that's really the first thing in vaccinology, and with every study we're doing, is the leading thing we're looking at is safety. And that one of the things that people have said about, and so I guess we can go to the next slide, thanks, is that, how do we know the vaccines are safe? How do we know it's okay to use these vaccines? How come they happen so quickly? And so no corners were cut with making these vaccines or testing the vaccines. Basically what happened is that we did things in parallel, so we did things at the same time, which normally would have been done in series. And part of that was because of having funds, that the government provided funding so that the companies were able to produce the vaccines and continue through in the clinical trials in a very rapid basis. The other thing, too, is that the data was provided to the FDA in almost real time. So instead of the typical thing is where we got all the data and they gave it to the FDA at the end of the study, we were giving information to the FDA all along. So it made it easier for them to be able to review. But it didn't cut any corners. The other thing is that, people say, well, how do I know this vaccine's safe? This vaccine, we've now had literally over hundreds of millions of doses that have been delivered. And so it is probably the most evaluated vaccine that we've ever had. And that from the clinical trials, what we've seen is that the side effects, the main thing is that pain at the site where they're getting the shot, and that they may sometimes have some headache and fatigue, but these are short-lived and that they really don't last past a couple days. And then when they've been used now in the EUA, the emergency use authorization, we haven't seen any difference in patterns. The only two things that we've seen that have happened very rarely that we've seen now because of the hundreds of millions of doses that have occurred, one is the myocarditis and the other one is this abnormal clotting. The myocarditis, there's some swelling of the heart muscle. It sounds terrible, I agree, but that is happening in the incidence of like 2 or 3 per 100,000. It's happening mostly with the second dose. It's still mild, and that typically the treatment has been with Motrin, ibuprofen, and the children, if they've been hospitalized for a day or so and then go home. The clotting has happened in the incidence about 1 in 500,000, and honestly, absolutely true. The incidence of getting hit by lightning in Ohio is 1 in 500,000. So it's literally the same incidence, the same likelihood of getting hit by lightning. And so if you look at the benefits of the vaccines, they far outweigh even those very rare adverse events, and certainly the mild kind of side effects that people are getting a day or two after the vaccine. What the FDA was able to do was use what's called this EUA, emergency use authorization, because there was the pandemic, because there was an emergency, and there was no effective treatment or prevention available for this virus. And so that's what the EUA was. The EUA was enacted as far as that after the FDA had data to be able to see at least 2 months of safety data from at least 50% of the people that received the vaccine, that's when they reviewed for the emergency use authorization. And the reason they chose that is because there's a lot of data to show is that if you have not seen a side effect from a vaccine in 6 weeks, you're just not going to see it. And basically, if you don't see it in 2 weeks, you're not going to see it. So the 8 weeks really is to be even extra safe. Just to go along that a little bit, then people say, well, if the emergency use authorization given in 2 months, why did they just give the approval for the Pfizer vaccine in the 16 and above? I mean, it's been a lot longer than that. And that then goes back to the rules that the FDA has, is that you have to have at least 6 months of safety data from the time the last person received their last study vaccine or study agent. And so that's, again, being incredibly cautious because we want to make sure things are safe. But that's why it took until last month so before the vaccine was approved. And now it is approved for 16 and above for the Pfizer vaccine. I think the Moderna vaccine and the Johnson & Johnson are approved for 18 and above. I think that authorized for 18 and above. I think that the Moderna vaccine won't be long before it'll be authorized from 12 and above, and I think that the Moderna vaccine probably will be approved soon too. So if people have questions, the place I would recommend going is the CDC. It's www.cdc.gov. This is on the last slide, but that's all right. And that they have great website there for parents and medical people too, to really give you a lot of information. So then as far as the vaccine safety we're at here is, like I said, is that the serious side effects, one of the things that people have also said about, well, I don't want to get a vaccine because I don't know what the long-term effects of the vaccine are. And I had to think about that one a little bit because that's not something I think about with the vaccine. I realized what people were saying as far as that if you take a medicine and you're taking a medicine every day, say like you have high blood pressure, diabetes, or high lipids or something like that, is that there's a possibility months or years down the line by the accumulation of medicine you have something that occurs that didn't occur right away. But that's not what happens with vaccines. With the vaccines, if you're going to get a side effect, it happens now, and that you're not going to get something that's going to start 2 months from now or 6 months from now, a year from now. So when people are saying, I'm nervous of getting a vaccine because I don't know what the long-term side effects of the vaccine are, there really aren't long-term side effects. That if you're going to get a side effect, you're going to see it very close in association with the vaccine administration. So, okay, you can go ahead to the next slide, and then I think the next one after that. So how will the vaccine protect me? And so as Dr. Wong is mentioning, as far as really, I think, important to understand a little bit, as far as, again, nuance, but it's important, the difference between infection and disease. And I think taking a step back, too, is remember, COVID means the coronavirus, and a coronavirus typically causes a cold. So if I drew blood on any adult, I'd probably find antibodies against 3, 4, 5 different coronaviruses you had during your lifetime, and you had a cold, and you don't get that sick. And the reason COVID is different is because we don't have the immunity in the population so that you're not protected. You really don't have any immunity, and you get infected, you can get really sick. So the COVID, an infection means that I am doing a PCR swab or something similar to that, and I'm finding evidence of the infection in you, finding evidence of the virus. PCR is not a culture, so just because I found a PCR does not mean that you're contagious, but we assume you are because we can't prove you're not. But it's not the same thing as a culture. And then disease means that you're infected and you have symptoms. And the thing with COVID is you can have symptoms all the way from asymptomatic or just a mild runny nose to death. So it's obviously a huge spectrum of illness here. And that's one of the things where people are getting a little confused about too, and very understandable because it's a difficult message, is that people that have been vaccinated, that the likelihood that you're going to get severe disease, and severe disease I mean to where you're hospitalized or you're in the intensive care unit or dying, is dramatically decreased in people that are vaccinated versus the unvaccinated. If you look since January of this year, 97.5% of the people that have been hospitalized with COVID-associated illnesses and 99% of the people who have died with COVID-associated illness have been unvaccinated. If you look at it the other way and say, if I've been vaccinated, what's my protection? Still at 6 months after vaccine, it's been 93, 94% protection against hospitalization. And the Pfizer vaccine, where there's some data for what's called an effectiveness study, where it's basically giving the vaccine in a real world setting. So you're going to the pharmacy, you're going to your doctor, whatever. This was using the database out of Great Britain. The Pfizer vaccine was 93% effective against the alpha, so the original variant of the COVID, and 89% against Delta, against hospitalization. So it's very effective, and it's very effective still against the Delta. So I think that's one of the things that is really important for people to remember. And that why do we want to vaccinate people? Well, one of the things is that we get a better, a stronger immune response with a vaccine than with the natural infection. We know that people that have been infected can get reinfected, and we know that they can get sick. And we've had studies to where it shows as far as that people that had COVID and then they either decided to get vaccinated or not get vaccinated, and they followed them along. The people that didn't get vaccinated had a 3 times higher risk of getting COVID again compared to the people that did get vaccinated. And so the vaccine is safe, the vaccine is protective, and the vaccine continues to be protective, and especially against the most important things that we're looking at, which is hospitalizations and death. So I think that the next slide then. So some of the things then, what the vaccines don't do. So the COVID vaccines, they don't give you COVID. This is not a live virus vaccine, so it can't give you COVID. It does not cause you to test positive for COVID. You're not going to shed COVID because of the vaccine. It does not alter your DNA. The mRNA or the adenoviral vector vaccine for the gene, those are chewed up within 2 or 3 days by our own body. There's nothing that lasts except for the antibodies against the infection. And then it does not impact your fertility. There's been a lot of misinformation and people saying about how the virus will make you infertile, and the vaccine will make you infertile, and that's just not true. It's unfortunately misinformation that people are spreading. Next slide. So as much as we have learned about the virus over the last 18 months, and if you really think about it, it's pretty amazing. 18 months ago, or 20 months ago, I guess, we didn't even know this virus existed. And so in that time, the amount we've learned has been amazing, but we still do have a lot to learn. And that we want to know, to look as far as saying, how well does the vaccine protect somebody with a weakened immune system? It's not dangerous to give somebody a vaccine, even if they're immunocompromised, but it may not protect them as well. And we're still trying to learn about that a little bit better as far as that if we can figure out who's the people that aren't going to respond as well to the vaccine. We're still recommending everybody get a vaccine, even if you are immunocompromised, but it may be that it doesn't, you don't respond quite as well to the vaccine, and why the FDA said about getting a third dose for people that have some of these altered immune systems. One of my colleagues, Dr. Laura Danziger, is actually going to be starting a study next month of looking at giving a COVID-19 vaccine to children with immune compromising conditions so that we can get some better data about that. And then how long the COVID vaccine protects people. One of the things that we want to know is what's called a correlative immunity. So how much antibody do we need to protect? And that we still don't know. We know if I give a dose of vaccine, we get a good antibody response. And we know if we give vaccine that people are protected, but we don't know exactly what level of antibody is needed for that protection. And that's one of the things that we're looking at, and that's why in our clinical trials we're having people stay in the trials for 2 years so we can try to understand a little bit better as far as what is the level of antibodies that we need for protection. And then we're still trying to decide exactly or figure out exactly about herd immunity or population immunity. We're saying we would like to see 70+% of the people vaccinated. I mean, if I could get 90% of the people vaccinated, that would be wonderful. And then, as I mentioned to you before, is that we're still learning about the vaccine efficacy against the variants, but from the data I was telling you about, that one study out of Great Britain, the Pfizer vaccine, the Moderna vaccines have been similar, has had still very good effectiveness against the variants too. So my take home of all this is that the vaccines are safe, the vaccines are effective, the vaccines are immunogenic, and that when the vaccines are available for your children with your age group, please go get them vaccinated. So I think then to turn it over to Dr. Shafson. Is that right? Or is it back to Dr. Wong?
No, I think we're going to turn to Josh, and just a little introduction, if I may, Josh. Most of the information that Josh is going to share with you is something that we've been sharing with the school administrators for probably 8 or 9 months, and updating it as we learn more, but it has to do with what we call the bundle and masking and so forth. So Josh, if you could please go ahead.
Thanks very much. Hello, everybody. So next slide, please. So what is a bundle? A bundle is a set of evidence-based interventions that, when done reliably together, affect a desired outcome, which is a fancy way of saying I do something makes a difference, it helps. If I do a number of things together, it gives me even more benefit. And if I do them consistently together, I get maximal benefit. And people often ask, what's the most important piece? Should I do this one thing or this one thing? And the answer is really doing as many pieces of the bundle as you can consistently will give you the best result. There is no one agent or one action in the bundle that's better than another. And this is just an example of what we've talked about. I'm sure you've heard different forms of this over time. This is an earlier slide, but we talk about distancing. So distancing is not automatically 3 feet or 6 feet. The virus doesn't have a imaginary force field that can't take it past a certain amount of space. So the more distancing, the better. But what we look for is a minimum of 3 feet. With masking, we encourage masking as much as possible, and I'll talk a little bit more about that and how it's really proven to be very successful. Hand hygiene has been around since the 1840s, and it is the single most effective way to prevent transmission of any disease. And the recommendation is that kids learn now how to wash their hands and keep their hands clean. It will keep them healthy throughout their lives. And then the last is cleaning. And while people have focused on intensive cleaning or using special agents or really investing in different technologies, the bottom line is that it's all about being consistent. This virus is very easily killed with alcohol or hydrogen peroxide. It doesn't need high-level disinfection. And so allowing it to dry out, allowing it to be exposed to the sun, or wiping it down with a simple disinfectant like a kitchen disinfectant will be very effective. And so it's really more about doing that consistently. And just one word on the image there. So the reason that I focus on hand hygiene rather than cleaning is because the way that the virus transmits from surfaces is by someone's hands, unless somebody is licking doorknobs, which I recommend against. But if you imagine that it's on a surface and it's on a doorknob, somebody will touch it and then touch their mucous membranes, touch their eye, touch their face, and that's what makes them sick. But if you perform hand hygiene between the doorknob and your face, then you've stopped the chain of infection. And so really the trick is to consistently disinfect your hands on a regular basis. Next slide. So a lot of questions about masking and a lot of valid concerns because it's not something that we've done historically. So next slide. The purpose of this slide is to try to frame the question. So the goal here, as Dr. Wang stated early on, is that kids attend school. We know that not attending school is harmful to them, to their development, to their academic achievement, to their emotional well-being. And so really, we need to make school safe for kids. And what we found was, and on the link here is a study from North Carolina, we saw a similar situation in Southwest Ohio, and it was reported in a number of places in the country that when school systems followed the bundle, and all of them included at least masking, distancing, and hand hygiene, in-school transmission, so acquisition of the virus while at school, was lower than being out in the community. And this was consistently shown over and over again. If we do nothing for the kids in terms of precautions around COVID, we will see more COVID disease. And we're certainly seeing that so far, and we'll continue to see it. This means that kids will not only be ill, but they'll be missing school. They won't be in school in person, which is harmful to them. And so the evidence, when we say, how can we have kids be in school safely, the evidence really favors masking as opposed to not masking. And really, if we're not going to mask, then we need to come up with something else that's going to work. We can't send our kids to school unmasked and hope for the best. I don't think it's fair to them. Next slide. So how do we know that masks are effective? Well, there have been a number of studies, but probably the one that's most cited was a large systematic review and a meta-analysis. And what that does is that takes a number of different studies and combines them. And it was really nicely done, came out pretty early in the pandemic, so used some pre-pandemic data as well. And what it showed was the distancing, so the 3 versus the 6 feet. It was international, so it was 1 meter versus 2 meters. It also showed that masks were 85% effective, meaning that if you were to wear a mask, you were 85% less likely to become infected than if you weren't wearing a mask. Hard studies to do, hard to know, but when they pulled all the data together, they saw a significant effect for masks, which is really, it's very helpful when we look at evidence to say that that is a reliable result, that's probably where the truth is. Next slide. So lots of questions about adverse effects of mask wearing. So probably the most common one that I hear is carbon dioxide, that kids will re-inhale carbon dioxide, it'll make them faint, it'll affect their physiology. And the truth of the matter is that that's just not the case. So you've seen us sit here and talk for a while, and we've been chatting away with our masks, and we haven't re-inhaled our carbon dioxide. The way that that happens is breathing into a bag or into a plastic bag. If I were doing that, yes, I might have passed out by now. But with a mask, it simply doesn't happen. One of the studies that came out that got a lot of media attention has since been retracted. And when I've tried to look for the studies that are claiming the carbon dioxide accumulation, I'm having trouble finding them because most of them are retracted. It doesn't mean that there's definitive evidence to the other side, but you have to be wary of a splash of a title of a paper that's reported by the media versus something that stands the test of time a couple of weeks later. There are studies that show the opposite, that show that kids wearing masks, walking down halls, down to the age of 2 and even younger, that the oxygen in their blood doesn't change at all. All of those studies are small scale, so it's not like they're definitive evidence on the other side, but the two can be fairly balanced. And the link here is for a Mythbuster. It's written by a couple of pulmonary specialists, a lung specialist, one of whom works here at Children's. And it's a really nice, it lays all the questions of masks out and answers some of the questions directly. And it's written for families. So I would encourage you to take a look, especially if you're looking for educational material. Next slide. So masks are uncomfortable. You've watched me fix this mask. You probably can see my glasses fog up. I would rather not be wearing a mask, especially when talking. However, there are ways to make it work. If you think about kids going to kindergarten, how many children do we have to convince or teach how to wear shoes in order to go to kindergarten? It's not crucial to their health, although it probably is helpful, but it's a requirement of going to school. Very similar with masks. So they can be uncomfortable, they can itch, they can feel warm. That can create anxiety and create a sense of I can't take a good breath, I can't take a deep breath. That can create the sense that your oxygenation is being affected, but it's not. It's just discomfort. And so focusing on comfort and focusing on accommodating kids with the mask is the way to go. Number one, finding the right material, the right color, the right elastic type, depending on how big their face is and their ears and what's comfortable for them. Another strategy is mask breaks. So taking breaks for a couple of minutes, especially if they're outside. Older kids are able to manage this themselves, but even removing the mask for 30 to 60 seconds will help feel refreshed and make the mask more tolerable. And I think that might be my last slide.
That's me. And so we wanted to finish with a couple of things. One is around COVID testing, because we've learned over the last couple of months that there's a fair amount of confusion out there, and hopefully we can clarify that in one slide. So the most accurate testing out there is based on molecular technology, meaning that these are tests that actually detect pieces of the viral RNA. They're done in a couple of different ways. The most common thing you've probably heard is PCR, which is just a technology to detect viral RNA and other forms of nucleic acids. That's what we do here in the laboratory. There's also a test out there that's called ID Now. Here's where some of the confusion starts, because ID Now is a rapid test. Excuse me one second. ID Now is a rapid test, but it's still a molecular-based test that we feel has very good performance characteristics. There's another class of tests out there that are called antigen tests, and by far these are the most common rapid tests that are out there. And so these tests are very reliable if they're positive for the most part, but they can have a lot of false negatives. And so depending on what situation one is using these tests in, they may not be appropriate. So we need to be wary that if we're making decisions about ending quarantines, getting kids back to school earlier, things like that, that these antigen tests have a higher rate of false negatives. And some common examples of that are what's out there now, Binax Now, and the vast majority of home-based kits. The other element about these home-based kits is that We're relying on on individual families to do proper sampling of their children, and that can be tricky to do well. It's not particularly complicated, but it's something that's new to people, and if you're not starting in the right way, you can even increase your false negatives more. So that's where some of the confusion comes in. I think everybody sort of groups rapid tests into one bucket, and that's not necessarily true. The ID Now test that we do use here in the hospital under certain conditions is actually molecular-based technology. Hopefully I'm hopeful that that provides you with some clarity. We could certainly answer more questions around that during the chat. Next. And so we're going to leave you with this slide before we turn to questions and a couple of other announcements. And this is a visual, a very simple visual that we've been sharing with our school administrators over the last several months. And what we're trying to show here is that what we're trying to achieve here is a balance between preventing and mitigating COVID illness among our kids, and as well as within the community, trying to balance that with what we call the unintended consequences of mitigation strategies. So as Joshua said today, we know that if the kids are not in school, it's a big problem. They develop mental health problems. We've documented that quite well. Some of you may have actually experienced that, unfortunately, with your own children, and also declining academic achievement. So we need to find a way to balance these two things, protection against COVID illness and keeping our kids in school and not realizing some of these unintended consequences. Next slide, please. Speaking of our kids, we want to call to your attention a virtual webinar that's being held tomorrow evening, specifically targeted or addressing the questions and the concerns that our kids may actually have. So we would encourage you to consider having your kids sign up for this virtual webinar going on tomorrow. Next slide, please. So that's it for the formal presentation. Please use the chat box for questions. We did have some questions pre-submitted that we can start addressing now while things come into the chat. But Ann, if we could go to the next, then final slide. These are some resources that are out there, our own COVID website, frequently asked questions about the vaccines and so forth that I think you could find very, very helpful. So Ann, I'll let you take it from here to bring up some of the pre-specified questions, and then we can see what comes in live.
Great, thank you. So first I'll just start with a question just about COVID in general. What percentage of children are we seeing that have experienced some of those long haul post-COVID symptoms?
Yeah, that's a great question, and it's actually very hard to know. We know that it does occur in children. We know that there are both adult and pediatric facilities that have set up clinics, and we have seen kids with long haul COVID. In terms of percent of kids who are infected who end up with long haul COVID, I think it's very difficult to say. It's not very common, but it certainly does occur. The other consequence that is more common in kids, but less common in adults, is MIS-C, or the multisystem inflammatory syndrome in children, which I don't have the numbers in front of me. They're not very common, but when they affect kids, they affect them quite significantly.
Yeah, I could add a little bit to that. I agree. It's very, very difficult to come up with an exact percentage because we are unsure of the denominator, and we're also unsure about the case definitions. You know, I think an important thing, I think, to convey, and this is not meant to convey panic or alarm or anything like that, but I think the three of us, Dr. Frank, Dr. Shafton, and I, we actually still take care of patients. I was in the ICU looking after kids last week, and I think the three of us would tell you that it feels different right now. About a year ago, 10 months ago, I think we all took a lot of comfort in knowing that, yeah, the kids could get infected, but they weren't getting very sick. We developed a number of protocols in children's for different treatment regimens and algorithms, and we hardly used them at all. in the last month and a half or so, it feels different. We're seeing more kids in the hospital that are sick from COVID, as opposed to a year ago, we were seeing kids who were in the hospital for other reasons and happened to be COVID positive. But over the last 6 weeks or so, we're taking care of more and more kids of various age ranges, and not necessarily kids who have comorbidities, who are sick from COVID. And we've actually had to use some of these protocols and some of these medicines. And that's not intended to sound alarmist, or to cause panic in anybody, just to sort of give you our perspective as people who are actually taking care of sick kids, that it's a little bit different right now, and we're hopeful that it doesn't get worse. And certainly, as we said earlier, I think one of the things that can be very effective is some of these bundles that we're talking about as we're in school, but also the vaccines. And it's, on a personal note, it's been very frustrating to be in the ICU, caring for kids who are pretty darn sick from COVID, and you kind of feel like this is preventable because they were all unvaccinated, and it's a bit frustrating to see that. So just a word of caution.
So I think maybe Dr. Wong, just to expand on that a little bit, if you look at last year around this time, is about 5 to 8% of all cases were in children. Currently, it's over 30% of the cases, the new cases in the United States, are in children. And children only, so 18 below, only make up about 20% of our population. So right now, children are actually overrepresented. So when this pandemic initially started, it was an infection or disease of people 60 and above. And now the highest incidence, the highest likelihood of getting infected is between 16 and 29. So it's really totally shifted. And the number of cases we had the last 2 weeks in kids have been the highest that we ever seen, ever, throughout the whole pandemic. We had over almost 500,000 children in the United States infected over the last 2 weeks. So that's just, again, as far as the reason that we're here tonight and trying to give you information and trying to impact why it's so important to try to do whatever we can to prevent this infection, because it is increasing. And like Dr. Wong was saying, is that we are seeing more children of needing some of the treatments, the monoclonal antibodies, other kind of things that we would like to have it so we prevent this, because as pediatricians, we really think very strongly prevention is much better than treatment. So if we can keep you from getting something in the first place, it's much better than trying to get rid of it once you already have it.
Thank you. And this is a question about while some of our younger kids are waiting for that vaccine to become available to them, what are some of the ways we would suggest parents continue to protect their children while waiting for that vaccine?
Well, first and foremost, it's hand washing, and it is a boring message to hear over and over again. But I often tell an anecdote. When I was seeing a young lady. She was probably about 8 or 9 in clinic, and she was very anxious. And she told me she was afraid of getting a disease. She was afraid of getting an infection. This is well before COVID. And I told her, I'm an infectious diseases doctor, so all I do is think about and interact with infections, but I very rarely get sick. I really don't miss very much work. I don't get fevers. And I think that the reason for that is that I just use hand sanitizer quite a lot, not in an obsessive way, but I just regularly incorporate it into my daily routine. And I think that it helps. And I haven't seen her back in my clinic, so I don't know if the recommendation worked. But the bottom line is that kids are very impressionable. Kids can learn behaviors. And so number one, first and foremost, teaching them hand sanitizer and how to properly sanitize their hands and when to do it, make it part of their meal routines, etc., is a wonderful thing. The second is that you want to try to avoid sick people when you can. If that means avoiding large crowds or crowds of people who are unmasked or places where you may be exposed, then that's a reasonable approach. But just trying to minimize exposure, trying to take advantage of the nice weather when it happens and be outside, that will definitely lower your risk. Other than that, I think parents taking care of themselves and and making sure that they are performing hand hygiene, masking when they can, that they're getting vaccinated, will help protect their children as well.
So I think it would just be, and just reiterating what Dr. Shafson had multiple slides on as far as a mask. And so the mask, I think, too, people ask, well, how does it work? And it can really work in two ways. One is that if I'm sick, actually, if you look at it, is that a lot of times transmission, so me giving it to Dr. Shafson or Dr. Wong or Ann, it's happening before I even know I'm that sick. That I may not have symptoms yet, but I still have the virus in my nose. So I've coughed and sneezed or something like that. If I have the mask on, it may be a little bit gross inside my mask, but if I sneeze or cough, it's going to be stuck inside my mask. It's not going to be spewed out. The other thing is that, so that's one way the mask can protect you by keeping me from coughing stuff on you. The other thing is that the mask acts as a barrier the other way too. So if someone else were to cough or sneeze, it's going to have a barrier protection that doesn't come in to me as much. I think the other thing too is that the masks often offer a visual cue too, is that I look at somebody and said, oh, I've got that mask on, I'm supposed to stay a little bit away from somebody. So it's a reminder too, so it helps in that respect too, just to remember, stay a little bit apart from each other. Hopefully this is not going to be something that's going to be lasting a whole lot longer, but those are the ways that I can see that really can be helpful until a vaccine is available.
Yeah, and Dr. Frank's comments reminded me of a common concern that we've heard about masks, and that is that if you have COVID and you wear a mask, you rebreathe the virus, re-inhale the virus, and stay sick longer. And that's simply just not the way biology works and the way viruses work. So I want to make sure we have time for other questions, but I would eliminate that as a concern that you'll stay sick longer because you're wearing a mask.
And along that same lines of masking, do we have a particular type of mask that we recommend people wear?
So the CDC has a very nice recommendations and a website with nice graphics. What you want is something comfortable, form-fitting, that has at least a couple of layers, at least 2 to 3 layers. Typically that will be one of the paper masks like this mask that I'm wearing, or a cloth mask that has multiple layers. Gaiters that are very common and people will wear are single layer, very thin, as are bandanas. It would be better to use a multi-layered mask. If you are using those agents, you want to make sure that they're folded over. But really, it's about comfort, fitting your face, and then having multiple layers.
Okay, and then this is a two-part question about COVID. Do we have any information on how long antibodies last after getting COVID, and kind of what are the chances of getting COVID again after you've already had it once?
So I'll let Dr. Frank take that on, but I just want to point out that for some diseases, the presence of antibodies indicates that you are immune, but that's not true for all diseases, and it is not true for COVID. So the presence of antibodies gives you more protection than if you didn't have antibodies, the same way that wearing extra layers in the winter keeps you warmer than wearing single layers. But wearing single layers is simply, it neither is effective in the long run. And if you stay outside long enough, no matter how many layers you have on, you will get frostbite. So the key there is really asking about immunity and versus the presence of antibodies. And I'll let Bob take it from there. But one thing that he said in his comments really stuck out to me, which is that we don't know what the protective level of antibodies is for COVID. So the fact that they're present just tells us that there's been a response.
Right. And that's really what I was going to say, Dr. Shafson, as far as the antibodies tell you that you've had a response, but it doesn't correlate with being protected. And that's a frustrating thing. I wish I had that information to be able to tell you as far as that you need, say, a level of 100 and you're protected, or a level of 500 you're protected. We don't know. And so that's one of the reasons why we've been actually telling people don't go into the community and go get your antibodies tested, because I don't know what to tell you they mean, other than it means that you have them, but I don't know what level is important. What I can tell you on the positive thing, as far as that, if you look at that, which to me is the most important thing, is how well the vaccines are working, is that if people that have been vaccinated, the protective effect has been over 90% still at 6 to 8 months after vaccination. And if you look at it, the people that have been hospitalized or dying from COVID, it's almost uniformly in people who have been unvaccinated. 97.5% of the people who have been hospitalized, 99% of people that are dying of COVID-related illness have been unvaccinated. So I can't tell you exactly what level of antibody is necessary, but what I can tell you is the vaccines are working. And we hope that over the next year or two that we will know. We have some diseases like pertussis or whooping cough that we've been studying for hundreds of years, and we still don't know what the correlate of protection is. So it may be that we won't know what level of antibody is important. Maybe one of the questions you were asking is that people initially, the CDC said, if you had COVID, you don't need to get tested again for COVID for at least 3 months. And so that a lot of people then said, well, that means can get infected again in 3 months. Maybe, but it was trying to say the other way. It was very unlikely that within 3 months you would get infected again. But we don't know exactly what point that you're going to get infected again, or if you're going to get infected again. Some people get it once and never get it again. Some people never get it. Some people get very mild disease. Some people get very, very serious disease. And I can't tell you who that's going to be either. And that's why, again, we advocate everyone to get a vaccine, because then we can protect everyone.
Yeah, and if I could add, I think we're not trying to be vague. I think some of this reflects that the immunity and the immune system are very, very complex, and it's much, much more complex than just an antibody level. That's only one component of the immune system. There are many other components that are much difficult to test for, much more expensive, much more complicated, more blood and things like that. So it's complicated, and then immunity varies across the population and across individuals. So we wish it was as simple as saying if you have X level of antibody, you are Y protected. But biology and immunity are just not quite that simple, unfortunately.
Thanks. That's a perfect segue into a few questions that we've received about testing. Knowing that COVID can sometimes mimic allergies, what symptoms would necessitate testing, and how should somebody know when they should test?
Yeah. So this has been something that has been really hard for physicians to manage, as well as everybody else. Most diseases that we know have a classical presentation. They will typically look a certain way. Flu looks a certain way, measles progresses a certain way, whooping cough looks a certain way. And when you see other symptoms, you say, I don't know if it's that. It's the average. COVID is not that way. COVID just has not shown itself to have a classic presentation. There are some symptoms that seem to be classic for COVID, for example, the loss of smell and taste, but cough or fever or sore throat, which are very vague and common symptoms, are also quite common with COVID, and we haven't been able to put together a clinical picture. So the key here is that you don't know if it's allergies or if it's COVID or if it's some other virus, and oftentimes what we do is we watch and we see if the symptoms go away. The challenge with that is that if it is COVID, you're potentially contagious, infectious, and you could potentially spread. And so now we're in a pandemic, we have to take a different approach. The recommendation that we give our employees is the first time you have these symptoms, get tested. So let's say I get allergies this time of year, it's probably allergies. But if I get tested and I test negative, then I know it's not COVID, and I can manage the symptoms, whatever they are. If the symptoms don't change, then it's unlikely that something else has changed, meaning that I've become infected with COVID. So what I would encourage folks to do is to not try to interpret the symptoms and wait for the right set of symptoms to test, but rather to look for changes in behavior, and to have a low threshold to have that initial test. If the those symptoms aren't associated with it and the symptoms stay, the kid still has a runny nose, then you don't have to test every day. It's not likely to turn into COVID. And truthfully, this is where antigen testing is probably most useful. The false negatives are especially higher in people who have no symptoms. So using it for asymptomatic people in order to go somewhere or do something is problematic. But testing somebody who has symptoms to look to see if it's COVID, a positive is much more helpful than a negative, but a negative in a symptomatic person is much more reliable than one in an asymptomatic person.
Yeah, and something related to that one of our pediatricians on the panel has been recommending is that, if you know your child has allergies and they're well controlled with medicines, to really do, when things are high level for allergies, is to really be mindful of allergy medicines, whatever those may be, and to keep up with those. Because if you're keeping up with those and doing what you usually do to control allergies, and you can interpret symptoms in that context. I think that's been really good advice by a real pediatrician.
And just one more question around testing. Should somebody wait to test negative before they can return to school and sports and other activities?
So every school districts and local health are going to create the thresholds. So to create a uniform rule across the board for all ages and all situations is extremely difficult to do, and nobody's really come up with the best pattern. I think that what schools and pediatricians and systems are trying to do are to find the best sort of balance between the two. So I'm not going to answer your question directly because I don't think that somebody should test every day and make sure that they're negative. I don't think that that's productive. But I think developing symptoms, if somebody has symptoms, thinking about what they could be, managing them in a certain way, sometimes testing is helpful. It's a balance, really depends on the context.
So I agree with Dr. Shavin saying, but there was just one, maybe Kevin, turn it the other way around, is that if I know I'm COVID positive, should I test again before I go back to school? And the answer to that would be no. And because the PCR can stay positive for 6 weeks or more, and so you can really confuse yourself. And this is where I was saying is that a PCR is not a culture. A culture is actually growing the virus or bacteria. We can see it alive in the tissue or on the plate or whatever. A PCR is just finding a piece of that virus, and it can stay around for a long time. So we're actually asking people, please do not test for cure because it can cause you more trouble than anything else.
Yeah, that's a great point. Early on, CDC was recommending, and some places were requiring healthcare workers or other people to test negative before coming back. We didn't think that made sense, and we haven't done it since the beginning, and we stick by it. We've had very good experience with it.
But we have followed routine quarantine protocols.
Exactly. Right.
That
Isolation protocols.
I'm sorry, isolation.
Yeah.
Well put, isolation, because once you're infected, you're being isolated.
Correct.
Well put. We have been following isolation protocols that are not just time-based, but also symptom-based.
Correct. So they're both a certain duration of time and resolution of symptoms, but we're not requiring a negative test before coming back to work for the reasons that Dr. Frank laid out.
Okay, and then we're getting to the top of our hour, so if anybody has any last minute questions, go ahead and put them into the chat box. But I thought this was a really good question. How do we counsel our children to do their best with the bundle when there's such contention surrounding some of the components?
And thank you for that question. I really, that cuts to the core of the challenge and the anguish that I think all of us feel around this pandemic. It's extremely difficult. I think that the way I would approach it, and I'll just try to be short so I can give other people an opportunity to talk, is the goal is to understand balance. Oftentimes we want to try to make things as crystal clear as possible, as a yes or a no. But especially as kids get older, they recognize that it's not that simple, that we live in the gray, in the in-between of the yes and the no, and that's how things really happen. And so trying to help people understand that there's a way to be respectful of each other, and there's a way to treat one another, as well as there's a way to follow practices that we believe are useful or we know are useful. It's not disrespectful when somebody else chooses to not to. It is disrespectful if that person who's choosing to behave differently tries to ridicule or criticize or attack somebody for behaving in a certain way. It's just not, it's not the way that we're productive. And truthfully, we teach our kids this every day. So really what I would do is I would encourage them to practice, but it's not, I'm doing it because other people won't do it, or I'm doing it and if other people don't do it, it's not good. It's, I do it because I know I should do it. I should wear my seatbelt. I should be in my car seat. I should eat well. I should exercise. I do that for me and for my family and for myself.
Then we did have one more question that came in around testing. Can we just talk a little bit about how we test for variants and how we know that somebody has Delta versus something else?
We don't. So that basically what you're doing is you're doing an epidemiological study so that the CDC or the Department of Health will test the strains and to see what variation it is. But on a routine test like your PCR or whatever, it's just going to say that you have COVID. The reason we're saying now is that it's Delta is because the last I checked, it was like 80 to 90% of all the isolates in Ohio are Delta. So you can pretty much bet that it's Delta just because that's what's out there. But on any individual person, we don't routinely check to see what variant of COVID it is.
Yeah, I mean, that gets back to, in order to detect these variants, it's a very different kind of test, if you will. It's a more elaborate test. It basically requires taking the entire sequence of the viral RNA and then matching that up to databases to see how they're different. So it's much more involved and complicated. So as Dr. Frank said, when he said we don't, that means that the standard test at Children's Hospital, we're not testing for variants. The health departments are sampling the population. In other words, not sampling everybody, but samples of the population to get a sense of the variants. And I think it's very safe to assume that the vast majority of COVID that we're seeing now is this Delta variant, which is typical behavior for a virus. At least to me, as a non-infectious disease person, I'm not surprised that these variants have arisen. This is what viruses do. And again, the best protection or the best mitigation against the variants is to give the virus less opportunity to replicate, because the less opportunity we give them to replicate, the less mistakes are going to be made and less these variants are going to come up. But that's what we're seeing now is this Delta variant. There are some reports out there of some new variants, which again is not very surprising. I think it remains to be seen if we can get enough people vaccinated over the next several months if these variants will or will not take a foothold. So we just need to see.
I think the existence of variants in COVID is not surprising. I think one thing that has helped COVID be a very effective agent and cause this pandemic is that it's come up with variants that have been very effective or even more effective. We've given it a great incubator by allowing it to propagate and propagate and propagate. And so it's a combination of the two. The reason that we know these variants are out there and we have this data is because we're looking for it, right? So it's the same as Dr. Frank was saying, that all the funding was put in place to keep the vaccine process moving as opposed to waiting. And so it's not that things were rushed, it's that things were done in sequence. Similarly, if we were to look at flu, and usually this stuff is published well after seasons and part of surveillance and part of research, but the papers are out there to talk about variants of flu, variants of other viruses. It's extremely common. It's just that we're all so intensely focused on COVID and testing COVID and looking at COVID that we're talking about all this now.
And that's all I had from the chat box for right now.
Okay, so just to remind everybody, this last slide, and hopefully you can see, we think that those are good resources. We thank you for your attention. We hope that this was of some help to you. We're certainly committed to trying to help in any way possible because, again, we share the common goal of keeping our kids safe and keeping them in school. So thank you for your attention and good luck.
Thank you.
Good night.